The learning objectives for this module are to review basic principles of cardiovascular physiology, describe the 4 general pathophysiologic mechanisms of hypotensive shock, recognize various etiologies for each mechanism of hypotensive shock, recognize differences in the clinical presentation of each mechanism of hypotensive shock, and cite the basic approach to treatment for each mechanism of hypotensive shock. Shock refers to a state of global tissue hypoxia, and it is most commonly the result of circulatory system failure. In these cases, hypotension results in the inadequate delivery of blood to tissues and subsequent tissue hypoxia. Prolonged tissue hypoperfusion can ultimately lead to multi-organ failure and death. Of note, shock may also result from conditions leading to increased oxygen consumption or inadequate oxygen utilization. For instance, cyanide poisoning may lead to shock by causing mitochondrial dysfunction and disrupting the utilization of oxygen by tissues throughout the body. In these cases, patients may present with normal or even elevated blood pressures. While you should be aware that these forms of shock do exist, we'll focus on hypotensive forms of shock throughout this module. Adequate tissue perfusion is dependent upon blood pressure. Thus, to understand the various mechanisms of shock, it will be helpful to first review some elements of normal cardiovascular physiology. Recall that mean arterial blood pressure is the product of cardiac output and systemic vascular resistance. Recall also that cardiac output is the product of heart rate and stroke volume, where stroke volume is dependent upon preload, myocardial contractility, and afterload. Take note of the proportionality relationships. For instance, afterload is inversely proportional to stroke volume, indicating that an increase in afterload will cause a reduction in stroke volume. Likewise, the systemic vascular resistance is dependent upon vessel length, blood viscosity, and vessel diameter, with vessel diameter being the most variable and physiologically relevant parameter. Using this equation, we can see that any reduction in heart rate, stroke volume, and/or systemic vascular resistance will lower blood pressure and, if significant, may precipitate shock. In order to achieve adequate tissue perfusion at all times, our bodies have regulatory mechanisms in place to maintain a relatively constant blood pressure. These mechanisms include the autonomic nervous system and the renin-angiotensin-aldosterone system, among others. A thorough discussion of the specifics of these mechanisms is outside of the scope of this module, but it will be sufficient to know that the primary goal of these mechanisms is to maintain a normal blood pressure. Thus, any insult that causes a reduction in cardiac output will be met by a compensatory rise in systemic vascular resistance. Likewise, any reduction in systemic vascular resistance will be met by a compensatory rise in cardiac output. In both cases, blood pressure will be pushed back towards normal. In the event that these compensatory mechanisms are inadequate to maintain a sufficiently high blood pressure, hypotension and shock may result. Shock represents a state of global tissue hypoperfusion and hypoxia, and its clinical manifestations reflect this. Common features of shock may include hypotension, tachycardia, oliguria, altered mental status, tachypnea, metabolic acidosis, and lactate elevation. Notable exceptions to this list will be discussed at later points in this module. Additionally, manifestations specific to the underlying mechanism of shock are generally present and should be sought out in order to guide empiric treatment strategies. One last point we'll address is the mechanism of lactate elevation and metabolic acidosis in shock. Tissues that are poorly perfused become hypoxic. Now lacking oxygen, these tissues must resort to anaerobic metabolism, a process that generates lactic acid as a byproduct. This lactic acid accounts for both the elevated serum lactate levels as well as the metabolic acidosis, with lactate acting to widen the anion gap. Next, we'll discuss pulmonary artery catheterization. The official indications for this procedure are listed here. However, it is worth noting that in the majority of cases, the etiology of shock can be determined with a thorough history of physical examination. For this reason, and due to the invasive nature of this procedure, pulmonary artery catheterization is not routinely employed and is rarely performed in the emergency department setting. However, it will be described here for educational purposes and because the parameters derived from pulmonary artery catheterization are useful for conceptualizing shock physiology. In this procedure, a catheter is fed through a systemic vein and towards the right side of the heart. It can be used to directly measure pressures within central veins, the right atrium, the right ventricle, and pulmonary arteries. Wedging of a balloon behind the pressure sensor within the pulmonary vasculature can be done to estimate pressures in the left atrium. This value, known as pulmonary capillary wedge pressure, is often used as a proxy for left heart preload. Additionally, a pulmonary artery catheter may be used to measure cardiac output and mixed venous oxyhemoglobin saturation. In combination with other measurements, data from pulmonary artery catheterization may be used to calculate systemic vascular resistance. Thus, we see that pulmonary artery catheterization allows us to determine many variables pertinent to the equation for mean arterial blood pressure. There are 4 generally recognized mechanisms of hypotensive shock, which are hypovolemic, cardiogenic, obstructive, and distributive shock. Within each category are a number of specific etiologies. It is important to keep in mind that for a given patient, several mechanisms of shock may be occurring simultaneously. Hypovolemic shock is defined as shock resulting from reduced intravascular volume. The specific causes of hypovolemic shock may be categorized as either hemorrhagic or non-hemorrhagic, depending on the source of fluid loss. As the name implies, hemorrhagic shock involves blood loss as the mechanism of reduced intravascular volume, and any source of significant bleeding could theoretically result in hemorrhagic shock. Alternatively, non-hemorrhagic shock involves the loss of fluid other than blood. Once again, any source of significant fluid loss could result in non-hemorrhagic hypovolemic shock, but GI losses, skin losses, renal losses, and third spacing are commonly implicated. In hypovolemic shock, the primary insult is a reduction in intravascular volume. The downstream effects of this are a reduction in venous return to the heart, a reduction in preload, measured as pulmonary capillary wedge pressure, and a subsequent reduction in stroke volume and therefore cardiac output. Examining this in the context of our previously derived equation, we see that this reduction in cardiac output has the potential to cause a reduction in mean arterial blood pressure. In an attempt to preserve mean arterial blood pressure, the body will buffer the fall in cardiac output by increasing systemic vascular resistance. However, if this compensatory mechanism is insufficient, hypotension and shock may result. Patients presenting with hypovolemic shock will often have other signs of volume depletion on physical examination, depending on the specific clinical picture. Additionally, the reduction in cardiac output disrupts normal perfusion of the skin and extremities, making them cold and clammy. This may also be exacerbated by the systemic vasoconstriction that results from the body's attempt to raise systemic vascular resistance and preserve mean arterial pressure. Treatment of hypovolemic shock focuses on fluid replacement. Depending upon the source of the fluid loss, this may involve the infusion of either IV fluids or blood products. Cardiogenic shock is a consequence of primary cardiac pump failure. In other words, some problem with the heart disrupts its ability to propel blood to the remainder of the body. The specific causes of cardiogenic shock are diverse and can be generally categorized as either cardiomyopathic, arrhythmic, or mechanical. Cardiomyopathic causes involve problems with the myocardium or heart muscle. Examples include myocardial infarction, myocarditis, and acute heart failure exacerbation, among others. In all cases, there is some issue intrinsic to the heart muscle that disrupts optimal contraction. Arrhythmic cardiogenic shock is a potential consequence of any rhythm disturbance that sufficiently compromises normal blood flow from the heart. In these cases, the arrhythmic disturbance may limit cardiac filling times during diastole or impair the heart's ability to beat fast enough to maintain cardiac output. Mechanical causes relate to structural problems with the heart, such as valvular abnormalities or wall rupture. In all cases of cardiogenic shock, the primary insult is a reduction in cardiac output, which has the potential to compromise mean arterial blood pressure. The body attempts to combat this effect by raising systemic vascular resistance via vasoconstriction. If this compensatory mechanism is insufficient, hypotension and shock may result. The clinical presentation of cardiogenic shock can be variable, depending upon the underlying cause. While the left and right sides of the heart are invariably linked, it can be conceptually useful to consider them separately. Isolated right ventricular dysfunction causes fluid backup into the systemic circuit. This typically manifests as edema and jugular venous distension. Likewise, the disruption in forward flow of blood from the right ventricle will cause a reduction in pulmonary capillary wedge pressure, which is used as a proxy for left heart preload. Conversely, isolated left ventricular dysfunction causes fluid backup into the pulmonary circuit. This typically manifests as pulmonary crackles. For the same reason, pulmonary capillary wedge pressure is instead elevated in cases of left ventricular dysfunction. To make things even more complicated, failure of one side of the heart often precipitates failure of the other side. Hence, sound clinical reasoning is important in interpreting mechanisms of cardiogenic shock. Findings specific to the underlying cause of cardiac pump failure should be sought out. Treatment of cardiogenic shock will vary significantly based on the underlying cardiac abnormality. For instance, myocardial infarction should be addressed with reperfusion, acute heart failure exacerbation might be managed with inotropic agents and diuretics, arrhythmic cardiogenic shock may require cardioversion, and valvular abnormalities may necessitate surgical repair. Obstructive shock is very similar to cardiogenic shock. In both cases, the primary insult is a reduction in cardiac output. This leads to a compensatory rise in the systemic vascular resistance. The defining difference between obstructive and cardiogenic shock, however, is the source of cardiac output reduction. As discussed previously, cardiogenic shock results from issues with the heart itself, be they cardiomyopathic, arrhythmic, or mechanical. Conversely, the mechanism of cardiac output reduction in obstructive shock is external to the heart. In other words, some process occurring outside of the heart is leading to the reduction in cardiac output. As with cardiogenic shock, the clinical presentation of obstructive shock is variable depending upon the underlying cause. Signs of right and/or left heart failure will likely be present. Also similar to cardiogenic shock, the effects on pulmonary capillary wedge pressure will vary depending upon which sides of the heart are failing. Causes of obstructive shock are generally categorized as pulmonary vascular or mechanical. Notable pulmonary vascular causes include pulmonary embolism and pulmonary hypertension. In both cases, high resistance in the pulmonary vascular circuit cannot be overcome and right heart failure ensues. Mechanical causes of obstructive shock include tension pneumothorax, cardiac tamponade, constrictive pericarditis, and restrictive cardiomyopathy, among others. In these cases, some force external to the heart disrupts normal cardiac filling and/or pumping of blood, accounting for the fall in cardiac output. Note that, here as well, the right ventricle is often affected first due to its distensibility and thinner walls. Treatment of obstructive shock should be aimed at removing the obstruction in question. For instance, this may involve thoracostomy for tension pneumothorax or pericardiocentesis for cardiac tamponade. Distributive shock is a consequence of severe peripheral vasodilation. In these instances, fluid volumes are generally normal, but vasodilation leads to sequestration of the blood in the peripheral circulation rather than returning it to the heart for use in perfusing vital organs. The causes of distributive shock are diverse. In most cases, chemical mediators, either endogenous or exogenous, serve as triggers for widespread vasodilation. Systemic inflammatory response syndrome, or SIRS, represents a very important example of this phenomenon. This term is applied to the clinical syndrome resulting from a robust inflammatory response that is triggered by some form of major bodily insult. The term sepsis is used if this insult is infectious in nature, but non-infectious causes such as pancreatitis, trauma, amniotic fluid embolism, etc. can serve as triggers for SIRS as well. Anaphylaxis is another such example. The sudden and widespread release of chemical mediators from mast cells and basophils can result in severe vasodilation and distributive shock. Anaphylaxis generally represents an IgE-mediated type 1 hypersensitivity reaction, though mast cell and basophil degranulation may also be triggered directly by certain substances, including opioids, vancomycin, and radiocontrast agents, among others. A variety of other drugs and toxins may induce a similar widespread vasodilatory reaction, including bacterial exotoxins causing toxic shock syndrome, or venom from certain snakes, scorpions, insects, or other creatures. Significant endocrine abnormalities represent another cause of distributive shock, though the specifics regarding these mechanisms are outside the scope of this module. Regardless of mechanism, the primary insult in distributive shock is a reduction in systemic vascular resistance, mediated through vasodilation. This has a tendency to cause sequestration of blood in peripheral circulation, causing a reduction in venous return to the heart and therefore preload. This is measured as a drop in pulmonary capillary wedge pressure. In an attempt to combat a fall in blood pressure, the body responds with a compensatory increase in cardiac output. This response is limited, however, as the aforementioned reduction in preload will limit stroke volumes and therefore maximum cardiac output. Hence, cardiac output may actually be variable in these cases, depending upon several factors. Worth noting is one additional form of distributive shock known as neurogenic shock. Neurogenic shock involves the interruption of autonomic pathways due to severe traumatic brain injury or spinal cord injury. The result is an alteration in vagal tone that leads to decreased vascular resistance and subsequent distributive shock. Similarly, these alterations in vagal tone may cause bradycardia, and thus the compensatory rise in cardiac output that is classically associated with distributive shock will not be seen. As would be expected, the clinical presentation of distributive shock will vary based on the underlying mechanism. One notable finding, however, is that patients with distributive shock tend to have skin that is warm due to widespread vasodilation. Treatment of distributive shock involves addressing the reductions in preload and systemic vascular resistance, usually through the administration of IV fluids and vasopressor agents, respectively. Bradycardia associated with neurogenic shock may require treatment with external pacing or atropine. For your reference, included here is a summary table detailing the various primary insults and compensatory responses specific to each mechanism of hypotensive shock. Thanks for watching, and we hope you enjoyed our module on shock.